talk here is going to be on the menstrual cycle. This is going to be very intense in physiology. We're not going to really talk about abnormalities here. And I want to talk about this because if you understand the menstrual cycle really well, and it would probably benefit you to watch this lecture a couple times, but if you understand the menstrual cycle really well, it's going to make a lot of other things, pathologies and disease processes in gynecology, much more easy to understand than if you don't. Understanding these hormone fluctuations and how the menstrual cycle works, if you understand that, you'll understand a lot of other things. You'll understand how contraceptives work. You'll understand how we get some of the symptoms of PCOS. You'll understand how cysts develop, some of the ovarian cysts. You'll understand what happens in menopause and why the hormones change, etc., etc. So, I encourage you to get acquainted with this cycle, and I think that will help you a great deal. So the menstrual cycle, typically, it varies from woman to woman, and so no one woman's cycle is the same as the next. And the menstrual cycle is going to not only vary from woman to woman, but it will vary at various points in her life. So the average cycle lasts 28 days. But you're going to run into women that maybe are 33 or 34 days, and some maybe are 22 or 23 days. It just varies. Now, there are two phases of the menstrual cycle, the follicular phase and the luteal phase, and you'll also hear these referred to as the proliferative phase, which would be follicular, and the secretory phase, which would be luteal, and it just depends on how you want to look at it, if you want to look at it based on what the ovary is doing, or if you want to look at it what the endometrium is doing. But for our purposes, we're going to call it the follicular and luteal phase. The follicular phase is variable, and it corresponds to the development of the follicle. So we're going to talk about folliculogenesis in a little bit, but it corresponds to the development of the follicle. And the follicle can take a variable amount of time to develop, from when the follicle begins to develop in its final stages at the beginning of the cycle to when it actually ovulates, which would herald the beginning of the luteal phase. That process, the length of that process can vary. So this is where we get the variance in cycles from woman to woman. Typically, the average is about 14 days, but that can be plus or minus 7 days. And that's probably going to depend a lot on how much FSH and LH the woman has in her bloodstream. So the more she has, the faster the follicle will develop, and so it'll be a shorter period, pardon the pun. And the less FSH and LH she has, namely FSH we're talking about here, the longer it'll take. Now the luteal phase, on the other hand, is more or less constant, because the luteal phase is driven by the corpus luteum, and the corpus luteum has a shelf life. The corpus luteum usually only lasts about 10 days, and then it begins to involute. And it takes about 4 days then for menses to kick in, where blood begins to come out of the vagina and the woman has her period. So this is constant. 14 days it's going to be the same for all women, about 14 days. So you put the two together, you get 28 plus or minus 7 days. The follicular phase can vary. The luteal phase is typically constant. Menses. So this is the loss of blood. This is what we know as the period. And it typically lasts 4 days. Now, by convention, the first day of menstrual bleeding, of menses, is designated as day 1 of the menstrual cycle. So you follicular phase, 14 plus or minus 7 days. Luteal phase, 14 days, so that gives us 28 days, and then you have menses, and that is going to be day 1 of the menstrual cycle. And menses lasts 4 days plus or minus 2, so some women will only bleed 2 days, some women only bleed 6 days, but on average 4 days of bleeding. Days 1 through 4 will be bleeding. And how much does a woman bleed? Usually between 20 and 60 mils of blood. So the superabsorbent pad will hold about 10 mils of blood, so she'll go through on average 2 to 6 mils of blood. And if you ask from woman to woman, she'll usually be able to tell you how many pads she goes through. She's not going to measure the mils of blood, so you have to know that a pad will hold about 10 mils of blood. So if she says she goes through about 4 pads in her average period, you know she's losing about 40 mils of blood. If she's going through 10 pads in a period, you know she's got menorrhagia. She's losing too much blood. A tampon usually holds about 5 mils of blood. All right, so this is the ovary. This is actually, here you see the uterus, the fallopian tubes, the fimbriae out here, and then the ovary. The ovary usually measures about 4 to 6 centimeters in its largest dimension. And the ovary has a capsule, and then on the inside you have follicles, and then there's actually a hilum in which the ovarian artery comes through. The ovary has multiple functions. First, we have the generation of mature oocysts, a process known as folliculogenesis, which we're going to talk about in a little bit. And then also it's an endocrine structure. It produces steroid hormones, progesterones, estrogens, androgens, as well as peptide hormones. There are various cell types in the ovary. There's, of course, the primary oogonia, which then form these follicles, which ultimately are going to ovulate and give the egg. These primary oogonia are derived from the endoderm of the yolk sac. And remember that a woman will have all of her, what will become her eggs in the form of primordial follicles from birth. But only a small minority will actually get recruited into ovum that are going to be ovulated. There's also granulosa cells. These are cells that create estrogen from androgens, which are supplied to it by the theca cells. And then there's the ovarian stroma, which consists of interstitial cells, some of which can become theca cells. Theca cells are responsible for making androgens, namely androstenedione, which it makes out of cholesterol. There's also connective tissue cells and then contractile cells. And it's thought the contractile cells help get the egg out to the fimbriae in a more efficient manner. So this is the structure of the ovary. It's an illustration. It shows you the primordial follicles, which then develop into the primary follicles, the secondary follicle, and then the Graafian follicle, also known as the tertiary follicle. And then this ultimately ovulates. We'll talk about this process in a little bit. This follicle then, after it gives the egg off, then becomes the corpus luteum. And it's at this point where we reach the luteal phase, and this creates progesterone. All right. Now this process of recruiting follicles, it takes about 2 or 3 months. So you're starting off with a primary follicle, about 5 or 6 will get recruited, and usually only one of them is going to develop into the tertiary follicle that then releases an egg. And what's going to drive that is going to be the number of FSH receptors that are on that particular follicle. The more it has, the more it's going to be able to develop, because a woman will go through points in her cycle where she's got low FSH, and so the more receptors you have, the more you'll be able to continue developing even though there's low FSH. Okay. So now we're going to talk about the endocrinology of the menstrual cycle, and this is where it gets really important, so I want you to pay attention. So as we start out with menses, day 1, all the hormones are low. LH is low, FSH is low, estradiol is low, progesterone is low. So what does that mean? Well, since our sex hormones are low, there's going to be low negative feedback on the hypothalamus. So the hypothalamus can now secrete GnRH. Because the hypothalamus is secreting GnRH, that's going to trigger the pituitary to release LH and FSH. LH and FSH will trigger the theca cell to create androstenedione, and then that androstenedione it moves over to the granulosa cell and gets converted to estrogen, namely estradiol. Now, I'm just going to preface here that the theca cell can only create androstenedione. It does not have aromatase, so it can only create androgens. The granulosa cell, it itself cannot make estrogen. It can only make it from the androgens that come from the theca cell, but it does have aromatase, and so the granulosa cell can create estrogen. Okay, so the LH and FSH that come from the pituitary gland, as it begins to rise during the follicular phase, it will also trigger the development of the follicle, ultimately into a Graafian follicle that can then ovulate. So you have LH and FSH that are not only helping you create estrogen, as the estradiol level is going to go up, but it also is triggering the development and maturation. Sorry, dropped something. It'll also trigger the development of the follicle and ultimately ovulation. Okay. Now, as the estrogen level goes up, you're going to have a negative feedback on the hypothalamus. And so the GnRH levels and the LH and FSH levels are going to go down. That negative feedback, however, will switch to a positive feedback when the estrogen level, the estradiol level, surpasses a certain point. And this is where we get what's known as the LH surge. So once the estradiol level surpasses a level, and that level is typically recognized as 200 picograms per milliliter, then it switches to a positive feedback, and that estrogen level will go up, and the LH level will go up exponentially. And that LH surge is going to trigger ovulation. Okay, so you get the LH surge, and then you have ovulation within a couple days. Okay, so here we have our estradiol. Estradiol is going to go up with LH and FSH, triggering the maturation of the follicle. The follicle will create estradiol. And so estradiol goes up, causes the FSH to depress a little bit, but as the estradiol hits a critical point, you're going to trigger the LH surge. The LH surge is going to cause ovulation. With ovulation, you have the formation of the corpus luteum. The corpus luteum makes progesterone. And remember also, estradiol is also responsible for the proliferation of the endometrial lining. So the endometrial lining is going to get progressively thicker with estradiol. Okay, so one other thing, the body temperature. So this isn't really important for our purposes here. But there is a way of contraception where the woman will measure her body temperature, and she'll know that when her body temperature goes up, that she's ovulating. And therefore, she should abstain from sex if she doesn't want to get pregnant. And this is a means, this natural method is a means by which some women will do contraception. Particularly, it's pushed within the Catholic Church because there is they don't permit birth control, artificial birth control. So this natural family planning is is one of the ways by which you can do contraception, prevent pregnancy. Okay, so this is folliculogenesis. Folliculogenesis is the development of these follicles, ultimately ending in ovulation. So there's these primordial follicles which develop from these precursor cells, and these will begin to develop into primary, secondary, and Graafian follicles progressively with the trigger of FSH and LH causing them to develop. So the primary follicles are suspended in prophase 1, and it will complete the meiosis with stimulation of FSH and LH. So the early primary follicle develops into the primary follicle, and what's happening is you get a proliferation of these granulosa cells from FSH and LH triggering that process. So then with the primary follicle, the only difference is you have multiple layers of granulosa cells. And you can see here the oocyte is in the middle. Now the granulosa cells are going to create estradiol, and ultimately you're going to get the formation of this zona pellucida. And the zona pellucida is a glycoprotein layer, and it plays a role in preventing multiple sperm from penetrating the egg. So you have the zona pellucida right here. What then happens is you get the secondary follicle, and the secondary follicle is marked by this antrum here, and the antrum is just this space, and it holds different nutrients which nourish the egg. With the secondary follicle, then you go on to develop this Graafian follicle, and it is at this point, actually this arrow should be here, but it's at this point where you complete the first stage of meiosis. And so you will lose half of your complement of chromatids. You're still going to remain you'll have two complements of chromatids, so two sister chromatids, but you'll be a haploid cell, so you'll be just N, whereas these are 2N. And so the half of the genetic complement is going to be lost in what's known as a polar body. So that just gets lost, and it doesn't really do anything. And so this is the Graafian follicle. That Graafian follicle then will be this precursor to ovulation. And when you get the LH surge, you get the ovulation here. And at this point, you're still suspended in metaphase 2, and it's only going to complete the second stage of meiosis once the sperm penetrates it, and you'll get another release of a polar body, and then at that point, you'll have a haploid cell that has only one chromatid per chromosome. Okay? And then the rest of this follicle then is going to develop into the corpus luteum, which we'll talk about in a little bit. So this is the tertiary follicle, and I believe this here is a secondary follicle, but this is a tertiary follicle. These are granulosa cells here. On the periphery, you have theca cells, and so these theca cells create androgens. Those get passed on to the granulosa cells, which are going to convert it into estradiol. And then here you have the oocyte, and this the zona pellucida here. And then this layer of granulosa cells is what's known as the corona radiata. And this little limb that connects it to the rest of the follicle right here is known as the cumulus oophorus. And it's going to be this portion, the cumulus oophorus, the corona radiata, zona pellucida, and the oocyte that gets taken up by the fimbriae and is going to go into the fallopian tube. And it's thought that the function of this cumulus oophorus is to sort of give the fimbriae an attachment point to help it more easily pick it out of the ovary. Okay, so let's move on to talk about the corpus luteum. So the corpus luteum is the remnant of the follicle that then becomes vascularized. And the corpus luteum is a progesterone machine. It pumps out tons of progesterone, up to 40 milligrams of progesterone a day. So a lot of progesterone. And the purpose of progesterone is to maintain the endometrial lining. If you don't have progesterone, you can't maintain the endometrial lining and you can't get implantation. And so one of the functions, the function of the drug known as RU486 or mifepristone is to act as a progesterone, an anti-progesterone. And so that's going to prevent implantation because it works against progesterone. It triggers progesterone withdrawal, and you're going to get necrosis. You're going to induce your menstruation. And so it works as a contraceptive in that manner. Now, it can trigger what would be known as an abortion. If you already have implantation, it's going to cause a sloughing off of that endometrial lining. So it can work as an abortifacient as well. But this creates progesterone. The corpus luteum creates progesterone and maintains the lining of the endometrium. Now, like I said, this only lasts about 10 days, and then the corpus luteum stops making progesterone. And that loss of progesterone then is where we get the triggering of menses. Now, if you do get a pregnancy and you get an implantation of the embryo is going to make HCG, human chorionic gonadotropin, and that will sustain the corpus luteum. So the corpus luteum will then persist, and that's what's known as a corpus luteum of pregnancy. And so then it will continue making progesterone, usually up to 10 weeks, and then at that point the placenta will take over to sustain the lining, make progesterone. Now note that the corpus luteum is very richly vascularized, and that is why a corpus luteum cyst will often have blood inside the antrum. And so you can see the blood here, and those corpus luteum cysts can become hemorrhagic, and that can be problematic if you get these corpus luteum cysts. So menstruation occurs if there's no implantation by day 24. Remember that a woman's fertile period, her most fertile period, is going to be between day 20 and day 24. At day 20, you have a nice, lush endometrial lining all ready for implantation, and that will last until about day 24. If by day 24 there's no implantation, the corpus luteum begins to involute, and it stops secreting progesterone, and then you go into progesterone withdrawal. So progesterone withdrawal is going to cause constriction of the spiral arteries. That's the arteries that are part of the endometrial lining that nourish it. And that constriction is going to cause endometrial necrosis. With endometrial necrosis, it's going to trigger the release of inflammatory mediators, which include prostaglandins. And the prostaglandins are going to contribute to this menstruation process. The prostaglandins are also what cause the pain that come with menstruation, and it also causes smooth muscle contraction, and that helps the uterus get rid of the menses. Now you have multiple layers of the endometrium. There's a functionalis layer, which is the proliferative layer of the endometrium, and there's also a basalis layer of the endometrium, and that basalis layer stays. The basalis layer measures about 2 millimeters. The functionalis layer gets up to about 1 centimeter, 10 millimeters in length, in depth. And that's going to be the layer that is lost. So this is where we get the names for proliferative and secretory phase. So if you go back here, during the follicular phase, you have proliferation of the endometrial lining, and then during the luteal phase, you have the secretory phase of the endometrium, and where that gets its name from is what's happening is the progesterone is stimulating vacuoles within the endometrium to migrate to the distal part of the endometrium and expel content, so you're getting a secretion. And so that's where it gets the name secretory phase. So you have different names for these phases, but it's really the same concept. So a follicular phase is dominated by the follicle. The follicle is making estradiol, and the estradiol is causing the endometrial lining to proliferate. And then during the luteal phase, it's dominated by the corpus luteum, which creates progesterone. And the progesterone is causing the endometrial lining to release that glycogen. Okay? Now, across the lifespan, you have variances in the LH and FSH. So I just want to touch on this very briefly. In childhood, the LH and FSH levels are, for a short period of time, high after birth. The cause from that is going to be because of maternal hormones. And so, for a short period of time, they're high, but then it begins to fall within a few months of life. So FSH will be higher than LH during childhood. And then during puberty, the gonadotropin levels will gradually rise. Interestingly, they rise during sleep. So the sleep-associated LH increase is one of the first signs of puberty. As the gonadotropin levels rise, you get recruitment and development of the follicles, and ultimately that's going to result in the first menarche. Or the first menstruation, which is menarche. Because you have recruitment and development of those follicles, you're creating estradiol, and estradiol, then as those levels go up, it's going to give rise to secondary sex characteristics that we see in puberty. And at puberty, you transition into a state where the LH level is greater than the FSH level. And then, of course, there's the fertile period, and then where a woman's of childbearing age, and then you hit menopause. And menopause happens when the follicles decrease, and then the amount of estradiol and inhibin therefore decrease, and so LH and FSH are going to increase, and then the woman will go back to a state where the FSH is greater than LH. Now, because the LH and FSH increase, when she does recruit follicles, which does happen during that sort of perimenopausal period, when she does have her periods, she's going to have a very short, or a relatively short, follicular phase because the FSH level is so high. And so that's where you get the sort of shortened follicular phase in what may be perceived as metrorrhagia that occurs during the perimenopausal period. And it also may explain the increased prevalence of twinning. So it makes sense that if you have higher FSH, it's going to be easier to cause the development of more than one Graafian follicle. And so those, you may have two follicles that ovulate. And so then if you're releasing two eggs and you get fertilization, you'll have fertilization of two eggs and you can get twinning. And we know that in older women, women who are perimenopausal, so in their mid to late 40s, they have a much higher incidence of giving birth to twins. Now the LH, which is high, is going to still stimulate the theca cells, and that will create androstenedione. That androstenedione can get converted peripherally into estrone. And estrone is the major estrogen of postmenopausal women, whereas in premenopausal women, the major form of estrogen is estradiol. Okay, so just to recap, the menstrual cycle is divided into two stages. The follicular phase, which has a variable length, on average 14 days, but plus or minus 7 days. At this point, estrogen is dominant, and that estrogen allows the endometrial lining to thicken. You get ovulation, and then it is the cycle is then dominated by the corpus luteum. Hence, we call it the luteal phase. It lasts about 14 days, and it's progesterone dominant. And progesterone helps stabilize the endometrial lining. Remember that the LH surge is what triggers ovulation and the formation of the corpus luteum, which is a progesterone machine. The corpus luteum secretes progesterone and stabilizes the endometrial lining. And then once the corpus luteum involutes, if there is no pregnancy, then you get progesterone withdrawal, which results in spiral artery constriction and necrosis of the endometrial lining and ultimately menstruation. All right, so that is it. I hope this made sense to you, and if you have a good grasp on this, it will make a lot of other things in gynecology, physiology much easier. You'll be able to understand the pathologic processes and have a much greater grasp on them. Any questions? Write me a note below.